Have you ever treated a patient with schizophrenia who seems withdrawn and unmotivated and nothing you do seems to help? You might be misidentifying the root cause. Today we are breaking down the critical difference between primary and secondary negative symptoms. This distinction is the key to accurate diagnosis and treatment decisions. First, let us look at primary negative symptoms. These represent the authentic schizophrenic state. Think of them as a diminution or absence of normal mental functions. We generally categorize these into 5 main domains. First is alogia or poverty of speech, where there is a decrease in spontaneous talking. Second is affective blunting, where the range of emotional expression and facial reactivity is reduced. Third is avolition, which is a reduced desire to initiate or persist in goal-directed activities like hygiene. Fourth is anhedonia, which is the reduced ability to experience pleasure. And fifth is asociality, or a lack of social drive. When these symptoms are durable and stable over time, we call it the deficit syndrome, and they are robustly correlated with long-term functional impairment. But here is the critical part. You must distinguish these from secondary negative symptoms. These are presentations that look negative but are actually imposters caused by other reversible factors. For example, a patient might be socially withdrawn not because of a deficit but because they are terrified by persecutory delusions or hallucinations. That is actually a positive symptom driving the behavior. Or perhaps the patient looks apathetic and has low energy, but they are actually suffering from post-psychotic depression. A very common culprit is medication side effects. Extrapyramidal side effects, or EPS, can cause slowed movement and a lack of facial expression that mimics affective blunting. We call this neuroleptic-induced blunting. Finally, consider the environment. If a patient lives in an impoverished or under-stimulating setting, they will naturally withdraw. So how do you manage this clinically? Do not just look at a cross-sectional snapshot. Look at the longitudinal history, because primary symptoms are durable while secondary ones fluctuate. Use a hierarchical questioning approach. Ask yourself, is the patient actively psychotic? If yes, treat the positive symptoms. Is EPS present? If yes, reduce the dose or switch to a second-generation antipsychotic. Is the mood dysphoric? If yes, treat the depression. Is the environment impoverished? If yes, focus on resocialization. While positive symptoms respond well to medication, primary negative symptoms are notoriously difficult to treat, so finding and fixing the secondary causes is often the biggest win you can get for your patient. If you found this clinical breakdown helpful, please like and share to help others improve their diagnostic skills.